Hello? Can you hear me? It's okay, right? Okay. Good morning, everyone. My name is Cassandra Knorr, and it brings me immense joy to welcome all of you to our first of 4 sessions in our education series. We're very excited about this new education series that we've designed and developed based on your feedback. At this time, we'd like to recognize and thank our donors, Barb Tillender, and an anonymous donor for their kindness and generosity in helping make this education series possible. I'd also like to thank my colleagues, Marie Martinez, many of you as the social worker at the Memory Clinic, and Elena Caccioni, our registered nurse at the Memory Clinic, as well as members of Dr. Tartaglia's research lab, who have all been instrumental in making all of these sessions possible. There's just some housekeeping things that I need to mention before Maria introduces our featured speaker. So when you registered outside of the table, you received a care package which contains your registrant ID, the surveys, the general overview of dementia inside the folder, and some additional brochures. So the registrant ID will be used to help us anonymously gather feedback. So we strongly encourage you to please fill those out for us. And we'll come around to collect the post surveys once the session is over as well. We'd appreciate if you complete those as well. For those of you who are live streaming the event from afar, we also have a link online that you can, in the description box, that will lead you to the online versions of the questionnaires. At the end of the talk, we'll have plenty of time for questions and answers, so please save your questions till the end. And as some of you I see already have your coffee, but for those of you who don't know, it's just outside of this room. And that's pretty much it. So I'll give the mic to Maria to introduce our speaker.
Thank you for coming today. I have the pleasure of introducing my friend and colleague, Dr. Tartaglia. She received her medical degree from McGill University. She completed her residency at the Western University and did 3 years of clinical research fellowship in cognitive behavioral neurology at the University of California, San Francisco Memory and Aging Center. She runs a cognitive behavioral clinic here at our Memory Clinic, where she sees patients with neurodegenerative disease such as Alzheimer's disease, frontotemporal dementia, and other atypical dementias. Her clinical and research interests lie in a better understanding of the social, cognitive, and neuropsychiatric aspects of neurodegenerative diseases with a focus on frontotemporal dementia. She uses imaging, pathology, and genetics to better detect underlying pathology that cause cognitive, behavioral, and motor dysfunction. The ultimate goal of her research program is to provide early pathology-specific treatments to her patients. Dr. Tartaglia.
Well, thank you all for coming and braving the cold today. So like Cassandra said, I'll be around afterwards for questions, so we can just get started. So I'm going to give an overview of dementia and provide a little bit of update on what treatments are available as well as what's new in our field. So basically the main objective is to really understand that dementia is not a diagnosis, that really it's the starting point. Something has happened and we need to figure out afterwards what the cause of the change is. I'll tell you a little bit about what's new and the treatment update. So I don't need to tell people here that we really do have to pay attention to dementia. Unfortunately, dementia, the greatest risk for dementia is aging. And fortunately, we've been able to cure a lot of the diseases of the heart and cancers, and so more and more people are getting to old age, and because of that, dementia is becoming more prevalent. Actually, in the last few weeks, they've reported that in Britain, dementia has become the greatest killer. It's overtaken heart disease for the first time. In Canada, as of 2011, there were 747,000 people with Alzheimer's or related dementia. And you can see from the figures that this is a very, very expensive disease. And it's only expected to rise. So what is dementia? Okay, dementia is really a term that you ascribe when somebody's cognitive and behavioral symptoms are severe enough to interfere with their work or their usual activities. It's a decline from a previous level of functioning, and it can't be explained by delirium or a psychiatric problem. The cognitive impairment is detected and diagnosed. So you do a history, you do some objective testing, and you see that there's at least 2 areas that have been affected. So it could be memory, it could be language, it could be reasoning, visual spatial abilities, or a change in personality. It's not, it's not just memory. I know a lot of people think of dementia as related to memory, but we'll get into that. There's a lot of things that can change, and they aren't memory-related problems. Although I have to say that in my clinic, a lot of people will come to us saying that they have noticed a memory change. Mild cognitive impairment is actually the stage before dementia. And it's a stage where you know something has changed, you realize something isn't quite the way it used to be, but still able to function, doing quite well. Some people can even hold down a job, but they're obviously not doing it in the same way that they used to do. So, you know, usually we can detect an impairment, and usually when you do an objective test, like a neuropsychological test, you will notice that they're scoring in a range that is below the norm. But they are independent, and they're obviously not demented. Now, when we say dementia or mild cognitive impairment, those are umbrella terms. They're not a diagnosis. They're an umbrella term that encompasses many different causes. And so you see, a lot of times people will think, you know, of Alzheimer's disease because that is the most common cause, but there's other causes of dementia that really have to be entertained because it makes a big difference. You know, you wouldn't want to go around saying, well, you know, I have cancer and not really know whether you have lung cancer or stomach cancer. You would want to know what is the cause of your cancer. So these are the most common causes of what we call neurodegenerative diseases, but they're, and Alzheimer's disease tends to be the most common one. When you look time and time again, when people die and they donate their brains for autopsy, we see that always over 100 people, you'll get 40% of them have Alzheimer's disease, but that means 60% of the people have another cause of their cognitive impairment, of their dementia. And so when you think of treating people, you would think, well, you need to know what the cause is, because otherwise, how are you going to be able to treat the underlying problem? And even though we know that all these diseases do share some common elements, and one of the common elements is that there's these abnormal proteins. So you have these proteins in your brain that are, you know, serving a function, but they become altered in some way, and that alteration makes them toxic to the brain cells. And they're all different. So the ones that cause Alzheimer's disease are called amyloid and tau. They're different than the ones that you see in Lewy body disease, in Parkinson's disease. They're different from the ones that you see in frontotemporal dementia. And so, you know, when we're thinking of people going into clinical trials for a disease-modifying treatment, well, you really need to think about what is the underlying cause. Now, we're fortunate with imaging that, you know, the brains look different. So the brain of somebody with Alzheimer's disease in a more advanced stage does not look like the brain of somebody with vascular disease or Lewy body disease or behavioral variant FTD. Unfortunately, a lot of these pictures are from patients who are in more advanced stages. And so many of us are trying to work hard at figuring out ways to detect underlying causes of disease at earlier stages. So what is Alzheimer's disease? Alzheimer's disease is a disease whose criteria means that there's cognitive deficits that are evident on history and examination, that the persons usually complain about some memory problems, but not just that. Some people with Alzheimer's disease will only complain about a language problem. Some people will say just that they have visual processing problems or executive behavioral. And so now we actually have criteria for logopenic variant primary progressive aphasia, posterior cortical atrophy, frontal Alzheimer's disease. And so it's really important to think, you know, depending on which area of the brain this accumulation is occurring, you'll end up with different symptoms. Oops. So this to show you that in Alzheimer's disease, we do have some, you know, fairly decent imaging. The part that's been circled, actually, maybe I'll get a pointer. Well, maybe not. I don't know if I can bring up, no. So the part that's circled is the area called the hippocampi, circled in red. And that area in the normal, this is 65, these are 65-year-old people. The normal one looks, you know, it looks a little bit less full than when you were 30. Okay, everybody's brain starts to shrink at 30. But obviously, you know, the brain still looks quite healthy. When you have mild cognitive impairment, we know that there's some atrophy, some shrinkage of that area. And obviously, when you have full-fledged Alzheimer's disease, there's even more shrinkage of the brain. We also know that there's areas of the brain that start shrinking even before we see any signs, okay? And that's one of the recent discoveries, is that, you know, long before you have any obvious clinical change, there's actually changes in the brain. And so when we call this pre-symptomatic Alzheimer's disease, we see that there's changes in the brain that are even outside of these hippocampi. And so now with, you know, more sophisticated imaging, we can do that. We can figure that out. We have some really good markers for Alzheimer's disease. We've become very fortunate that we have a tag for the amyloid, which is one of the abnormal proteins building up. So this isn't currently covered by OHIP, but we're hoping that in the future it will be, and so that you would be able to detect the cause when it's Alzheimer's disease. Lewy body dementia and Parkinson's disease dementia are kind of like two sides of the coin. So in this disease, there's a protein that builds up called alpha-synuclein, but depending on where it builds up in the brain, you end up with different types of symptoms. So in Lewy body dementia, people will present with some fluctuation of their symptoms. They'll be, you know, doing really well at certain times and less well at other times. They'll have visual hallucinations. They will have what we call Parkinsonism, which is, you know, that slowness of movement, or, you know, the tremor, but really less than, you know, somebody with Parkinson's disease. In Parkinson's disease, these patients will begin with a classic Parkinson's, where they have a tremor, they're slow, they're more rigid, and then over time they start to develop the cognitive deficits. And that's really related to where the buildup of these abnormal proteins are. The imaging for Parkinson's disease and Lewy body dementia, unfortunately, has not been that helpful for us. We usually see kind of widespread shrinkage of the brain. There's no particular area of the brain that we can look at. Vascular disease, this is, you know, this disease hadn't really been well recognized. Until recently, we used to think of vascular disease dementia as being a dementia that occurred only after you had a stroke. So you had to have a stroke, and then 3 months later, you had to have this cognitive deficit that started to show up. We now know that is, you know, we all knew this because our patients would show up and they would swear they'd never have a stroke, and their families would swear, but their brains would look a certain way, which I'll show you, and they would have cognitive deficits, and their cognitive impairments were not those of Alzheimer's disease. So now we know that you can have probable, you can have possible, you could have, you know, mild cognitive impairment, and it all be due to vascular disease. And when we look at people's brains, fortunately, the imaging in this disease is actually quite helpful, because these sequences are, you know, sensitive to vascular disease. All that white fluffy stuff should actually not be in your brain. You know, we tolerate 1 or 2 little specks of this. You know, we call them unidentified bright objects. But you should not be accumulating this white stuff in the brain. And this disease is actually entirely preventable. This disease is really related to lifestyle and high blood pressure, cholesterol, diabetes, sedentary lifestyle, drinking, smoking. So this is one of the diseases that we really think is a preventable illness. And unfortunately, vascular disease can pretty much mix with anything else. So you can have Alzheimer's disease, the pure Alzheimer's, but you could have Alzheimer's and vascular disease mixed. And you could think that if you're going to have 2 strikes against your brain, well, your disease is going to be accelerated, and your symptoms will be worsening faster. And of course, you could have just vascular disease. Frontotemporal lobar degeneration is really a family of syndromes. This is, you know, less well known, but unfortunately affects people at younger ages, and so actually can be quite devastating. The disease used to encompass only 3 syndromes, which were behavioral variant, frontotemporal dementia, semantic variant, and non-fluent variant, but I'll get into that now it actually encompasses 6 syndromes, and so is quite a lot more common than we thought. So behavioral variant frontotemporal dementia is really, as the name describes, all about a change in your personality and your behaviors. These people will become disinhibited, apathetic, unempathetic, really not care so much about their families anymore, develop these ritualistic behaviors, change in diet. Their memories actually can be quite good, and their problems are more of an executive. And then you have, quite a significant genetic component to these people, and also, unfortunately, a number of them can develop some ALS. Their lifespan is quite a bit shorter than people who have Alzheimer's or Parkinson's disease. And their symptoms really come from where in the brain the disease is. The back of the brain of these people looks really good, but the front of the brain, all that black that you can see, and on the real brain, you can see that the front is quite shrunken, where the red is. All those areas become abnormal, but the back of the brain still looks quite good. And so, because those are your, really the personality for your social cognition, for your interpersonal relationships, these people, that's what they lose out on. Their visual spatial skills, which are at the back of the brain, are actually quite good and preserved till late in the disease. Now, there's a number of syndromes that are actually related to language impairment, okay? And 2 of them are related to frontotemporal lobar degeneration, and 1 of them due to Alzheimer's disease. These people, their main problem for the first few years of their disease is just related to language. So they're able to do many functions quite well without difficulty, but it's really in speech production or speech comprehension that their impairments lie. And I'll go through them. Semantic variant primary progressive aphasia falls under frontotemporal lobar degeneration, and these people are quite fluent, but they really talk a lot and not be able to say anything because they have lost comprehension. They've lost the meaning for words, for objects, for emotions. And when you meet somebody with this disease, you really understand that the basis of a lot of our relationships is based on understanding what the nature of that relationship is. And so that fundamentally changes in these people, and it can be quite devastating for their care partners. If they have left-sided atrophy, they really lose the language. If they have right-sided atrophy, which means shrinkage, they actually lose a lot of emotional aspects of relationships. And it's mostly caused by frontotemporal lobar degeneration. And as well, it's slower than, the other frontotemporal dementia syndromes, but faster than Alzheimer's disease or Parkinson's disease. And like I said, the symptoms that you display are really related to the part of the brain that is changed and where you're accumulating all this pathology, all these abnormal proteins. And for these people, the parts in red is the part of the brain called the temporal lobe. And that area is really important for understanding words, understanding relationships, understanding your, function in the world, and that's changed in this disease, which is completely different from non-fluent variant. So these people have actually a lot of understanding, and they retain comprehension until later in the disease, but they have so much trouble getting words out. They develop these problems with the motor aspects of words, and so can become mute, even though they retain what they know what they want to say, but unfortunately they're initially not able to speak the word, and subsequently are actually not even able to write the words anymore. It's an intermediate rate of progression, and there's also an intermediate rate of genetic cause. So as I've said, now we know that frontotemporal lobar degeneration actually has 3 other syndromes associated with it, and one of them is frontotemporal dementia with motor neuron disease, one is cortical basal syndrome, and the other is progressive supranuclear palsy. So actually, when you think of frontotemporal lobar degeneration now, it's actually not as rare as we thought, because when you put 6 syndromes in it and looking at people who are younger, there's quite a lot of people who are afflicted. So we now recognize that many people who have ALS, motor neuron disease, actually have a component of frontotemporal dementia. And this hadn't been recognized until quite recently, actually. As well, when we see our patients in our clinics with frontotemporal dementia, we're often sending them for EMG nerve conduction studies because they do have some motor weakness. And it's that actual motor weakness that kills a lot of our patients because they end up with swallowing difficulties. And so if you don't recognize that, your patients can get into a lot of trouble. And so, you know, one of the big problems we have in our field is people with frontotemporal dementia will be given a medication for Alzheimer's disease. And that medication can cause you to build up secretions. And the problem with that is that if on top of that you miss that they were not swallowing properly, our patients can end up with aspiration pneumonia. So you know, you can see that it really is important to try to understand what the cause of somebody's dementia is. We can't just treat with any medication just because we don't have a good blood test to do, like for diabetes or thyroid disease. Cortical basal syndrome is a really complicated disease because this illness presents with language problems, or it can present with behavioral problems, or it can present with motor problems. And eventually you get both of these types of problems. And one of the key features about these patients is that they lose the ability to perform really simple tasks. So, you know, holding your fork and eating becomes tough, picking things up with your hands. And so even though they have full power, they don't have any weakness, they end up not being able to do that. As well as, you know, the slowness, sometimes they have tremor. And the underlying cause of this disease has actually turned out to be quite difficult to predict. So we used to think this was a tau-based disease, and then we realized that there's people who have Alzheimer's disease as the cause of this disease, or they have TDP-43. So unfortunately, this illness is going to be very tough to treat, because when you think about the fact that you need to know what the underlying cause is and you have no way to predict it, they're not really being included in any clinical trials right now. Progressive supranuclear palsy is another one of these diseases where, you know, you present with this constellation of symptoms. These people will usually present with falls. They'll present with eye movement abnormalities, and they do have changes in personality, changes in the way that they function in terms of judgment, and the way that they can plan and organize. And there are specific changes in the brain that we can look at, but they don't occur in everybody, and they don't occur early on. So this disease also is really trying to, you know, put all the pieces of the puzzle together and trying to figure out what they have. This disease is usually caused by tau, and so we're having clinical trials in them. This picture is really to show you how complicated it is. When we meet patients and we get a history from them and do the testing, we come up with a clinical syndrome. But at the end of the day, we have to figure out what the underlying cause is to be able to hopefully treat them. And you know, what you see here is that a lot of diseases, it's very difficult to predict, because we now know when, you know, the patients have generously donated their brains for autopsy that we have a hard time predicting what the underlying cause is. And that means that it becomes very tough to understand what type of clinical trial they would benefit from. And, you know, you really need to move to trials to be able to figure out a treatment. And so, you know, it's been quite slow. Unfortunately, we do a lot of misdiagnosis. Although we want to pride ourselves that we're, you know, good at what we do, it's really tough, right? Because when you think about it, your brains have limited networks, and whatever affects that network will give you the same types of symptoms. And so this is in Alzheimer's disease where you have the most data. 78% in this study of 1,000 people had the correct diagnosis. 11% of patients were diagnosed with Alzheimer's disease didn't have it, and 11% had it and didn't get diagnosed. Now, you know, that's a big problem. You know, when you think about it in a clinical trial setting, that was a big issue. In 2013, they noticed 30% of patients in an Alzheimer's trial didn't have amyloid. and the treatment was anti-amyloid. So in cancer, that would be the same thing as putting, 30% of patients who didn't have small cell lung cancer into that trial. That means you're getting a toxic drug and you don't have the disease. There is no hope that it's going to help you. In cancer, they would have been sued. In Alzheimer's disease, we just said, well, oh, that's too bad. But since then, the clinical trials for Alzheimer's disease require that you have confirmation of the underlying disease. You can't get into clinical trials now for Alzheimer's without proof that you have this problem. Men were more likely to get diagnosed because they presented with some, behavioral or some atypical features, and this was in 1,600 people. But fortunately, in Alzheimer's disease, we actually do have methods for making a diagnosis. We can do spinal tap, cerebral spinal fluid, which we can measure a amyloid, A beta, or tau, and we have pretty good what we call sensitivity and specificity. That means we're pretty good at telling you whether or not you have it. It's not 100%, but actually there are very few tests that are 100%. We also have PET scans. Now, those aren't covered by OHIP. The spinal tap is. In the United States, there's a really large study underway where anytime you have a patient that you think might have Alzheimer's disease, but you're uncertain, they're being sent for PET scans. And they've shown this summer, after 4,000 people had been scanned, and I think they're planning on scanning 80,000, is that it actually made a significant difference in 60% where the diagnosis was changed. It altered the management of the patient. So we're hoping that, if this study continues to show such results, that will become accepted there and eventually will come to Canada too. And like I said, most clinical trials, you need to have a diagnosis of Alzheimer's disease. You can't get into the trial without it. So where are we in terms of dementia research? Well, like I mentioned, this is really a novel idea that your disease, the amyloid and tau, the underlying causes of Alzheimer's, are building up years before you have any symptoms. We now know it could be 20 to 30 years before, which means there are people who, for a long, long time, the brain beautifully compensates for any accumulation of these proteins. But eventually, it's kind of the straw that broke the camel's back. And this means that, these are windows of opportunity. If you had a good drug, you could screen people like we do in cancer. And so, everybody is really working hard at this. We now know that the disease spreads. It starts in certain areas, okay, and it spreads in the brain in a typical fashion. We know this for Alzheimer's disease. We know it for Parkinson's disease. We think it's probably true for other diseases too, but we don't have the proof right now. But people are working at this, and this idea that the abnormal proteins are building up years before has been shown in Alzheimer's, has been shown in Parkinson's, has been shown in frontotemporal lobar degeneration. So we know that this is a kind of a feature of neurodegenerative diseases in general. We actually also have proof that the disease spreads from cell to cell, okay? We didn't know this before. So it's not, I know, everybody wants a cure, and of course we all want cures. And so it's hard when people are in clinical trials or people are, people come to my clinic, it's like, okay, what's new? And at the drug level, I don't have very much. But in the understanding of these diseases, we actually have made considerable progress. And so we are optimistic, and this is why we're in this game. We think that, we're going to win. And it's not going to be, centuries away. We can see that every step that we take, we're moving in a direction where we actually are changing really significantly our understanding of these diseases. So in 2012, somebody showed that, you could inject Alzheimer's disease from a human into a mouse, and you could follow it in the mouse's brain. And the spread was similar to what was happening in humans. In terms of imaging, when we think of Alzheimer's disease, we used to have a marker to detect amyloid. okay, which is great because we could say you have Alzheimer's disease, but we know that amyloid doesn't track with a cognitive impairment. And really, that's what you would want. We know that tau dictates how well you do on the testing in function. And recently, there's been progress in that area, and so now we have a marker to be able to track disease progression with tau, another PET scan, and it's being used in clinical trials too. So, you know, if you give a drug, at the end of the day, you want it to remove the protein, amyloid, because that's what the drug is for, but you would like to see an effect on tau because you know tau dictates how you're going to do. And, you know, right now there's a lot of trials starting with anti-tau agents. Some of them in Alzheimer's, some in PSP, but you know, for us it's very important to have a marker to be able to follow because, you know, following people clinically, as you all know, people have their good days, their bad days. It's really tough when you're just asking people questions on pencil and paper to know how well they're doing because, you know, all of us, even whether we have disease or not, can do better on some days. And so when you're basing all of the results, all of the outcomes on these one tests, it becomes a little tough. And you know, a lot of trials have failed. And some of us think some of the failures are really based on the insensitivity of the tests. We also now recognize, I think, you know, families had been talking about this, the care partners had been talking about this, but it wasn't that well recognized in our field that a lot of illnesses start with changes in behavior. And that, you know, a lot of times, even outside of frontotemporal dementia, there was a lot of behavioral changes and patients end up in psychiatry or they're thought to not care or, you know. So now we understand that those networks that are affected by these diseases subserve behaviors. And so sometimes people's cognitions can be very good. They have very good memory and they have very good visual spatial function and good language, but there's a change in their personalities. And that's the first sign. And at that point, we should be intervening and not wait till the disease progresses so much that they have cognitive impairment. And I think what we're most excited about is that we now have really very good evidence that dementia risk is reducible, okay? So although, you know, more and more of us will hopefully live into ripe old ages, okay? People are, you know, a lot of diseases of the heart and cancers have been cured. We know that in countries that have been really proactive about changing your lifestyle, making modifications to, you know, the way you treat blood pressure and cholesterol and diabetes, have really had a significant impact on their incidence of dementia. So although more and more people in those countries are living to ripe old ages, we know that the rise of dementia isn't proportional. We know that, you know, diabetes increases your risk, so good diabetes care. We know that smoking increases risk. High blood pressure in midlife is a big contributor to a lot of these dementing illnesses. Education. We know that education is protective. Not just formal education, but being in stimulating environments, being in, you know, occupations that are challenging is good for the brain. There is some evidence that depression, obesity also increases risk. And we know that over and over again, physical activity and cognitive stimulation decreased it. So we are optimistic that just basic lifestyle changes could impact the incidence of dementia, which has huge implications for a society. We're not sure if it's just in the vascular dementia disease, because that one unfortunately had been under-recognized. People weren't imaging the brain, so oftentimes we'll have a lot of patients come to our clinics or their families and say, oh, you know, there's lots of Alzheimer's. But unfortunately, Alzheimer's was ascribed to all these patients, and when you get the family history, the patients had strokes and heart disease, and they were smokers, and they drank, and they had a sedentary lifestyle, and you're thinking they might not have had Alzheimer's disease. But because there was no imaging of the brain, we actually don't know. So it does actually make a difference to have an accurate diagnosis so you really understand what is your risk for Alzheimer's. There was a really actually impressive study done a few years ago in Finland. 3,050 twins were followed for 25 years, where I think only in Finland you can do this. And these people showed that midlife vigorous activity was associated with better cognition in old age. This was independent of all those risk factors and education and obesity and binge drinking. So it's really showing over and over again that, you know, exercise can make a difference. And we know that for the normal elderly. There's lots of evidence that people who are doing well and are older, you know, really benefit from exercise programs. You could delay the onset even if you were going to get the disease. There was less evidence in people with Alzheimer's disease, but unfortunately, some of these patients had been put in programs that were really not that stimulating. You know, a lot of these chair exercise programs where people can't get their heart rates up. But when you put people into aerobic programs, there's more and more evidence that you can actually have an impact on their on the progression of their illness. And like I mentioned, you know, there's over and over again, more and more countries are showing. So the U.S. has a number of reports now that there's declining rates of dementia. The UK recently showed that. Scandinavian countries, the Netherlands had been showing this for quite a number of years. And, you know, we don't think that Canada will, you know, will be far behind. We do think that being very proactive about your brain health throughout your whole life will actually have an impact on this. And like I mentioned, there's evidence that cognitive reserve resilience is really important. And so, you know, we encourage, you know, obviously I think education is encouraged in our society, but for people to keep challenging their brains throughout their lives. You know, a lot of people will retire at the age of 65 and, you know, they were in challenging work environments, but then they retire, and when you think the lifespan is 85, you're like, well, there's a quarter of your life where you have to figure out what you're going to do to keep your brain active. This very interesting study showed that youthful brains in older adults, there was you know, these people who were doing quite well, they had these networks in their brains that looked much younger than their age. And so, you know, once again, it becomes really important to keep your brain stimulated. A little bit on what's happening in treatments. So currently, there are 479 trials in dementia that are actively recruiting. This is, if you go to clinicaltrials.gov, it's a website that basically, if you're going to have a trial of any sort, whether it's observational or whether it's a pharmaceutical study, you have to register the trial nowadays. You can't just come up with your trial and put it out there. And so there, out of the 479, some of them pharmacological, some of them not. There were 39 that are actually actively recruiting in Ontario. Most of the trials are amyloid trials. So these are for Alzheimer's disease. We have a number of trials, mostly at early stages. So we now know that, you know, like I said, this disease starts decades before you show any signs. So we really think that a lot of the failures are because once the brain is degenerated, it's very tough to bring the brain back. So we really are trying to get at people at early stages of illness. So some of the trials are actually directed at the genetic population, which is very rare, unfortunately. I mean, fortunately and unfortunately. So that means not that many people end up in those trials. There's people who have ApoE4. This is a risk factor, not a genetic mutation per se. Doesn't mean you will get the disease, but puts you at higher risk. So those people have been, you know, enrolled. And, you know, people who end up in, you know, getting a scan or getting their spinal tap and they look like they have amyloid and tau building up in their brain, even if they're doing very well, they can end up in these trials. And, you know, the whole point is that if you could stop the disease, especially in these genetic families, right, where patients come from, there's huge families in Colombia, it's one of the countries, where thousands of people, and they're getting Alzheimer's disease in their 40s and 50s, and they're, you know, it's like, this is why we tell people, it's like, well, what is your family history? And when somebody says, well, I have 1 or 2 or 3 people, it's like, no, usually genetic means, 2 to 3, 4 people per generation, and it's, huge families, and everybody is affected in the majority. And that's when we think of this family has a genetic cause. So there are actually trials going on in collaboration between Washington and Columbia, and hopefully the point is to actually prevent the disease. So these people are completely normal. They've been tested extensively, but they do have the genetic mutation. Some of them already have amyloid in the brain. We know, it starts 20 to 30 years before. And so 10 years before their supposed onset, because throughout the family, they usually start the disease at the same time, 10 years before they get onto these drugs. And the hope is that they will never develop the disease at all. They'll never show any signs. So the readout of some of these diseases should be by 2020. And we're, optimistic in the sense of we do still believe that amyloid has an important role to play in Alzheimer's disease, as well to give definitive proof to us. If we're on the wrong track, we need to know that. We need to move, onto something else. One of the other targets in Alzheimer's disease and some of the other illnesses is tau. I've told you in Alzheimer's there's 2 bad proteins. We have now a number of trials aimed at tau, and this is really to try to stop the disease at, a stage where you think, okay, since tau is dictating how well you're going to do, well, if we can stop the tau. There's also people thinking about both treatments together, these combination treatments like you get in cancer. So there is a lot of activity. We do have room for optimism. A few years ago, they'd reported that these are monoclonal antibodies, so a drug specifically aimed at amyloid had given out good results, so that we have, big trials with these drugs. And just last week, they said that, there's ongoing benefit. We're all worried that, the initial results look good, but then is it a sustained effect? Because that makes the difference, right? And last week, they read out at the 2-year mark that there was still continued benefit in these people. So, let's say our optimism continues. We'll see. This is the issue with clinical trials, and one of the reasons that some of us are not so gung-ho about all these homeopathic. Clinical trials are hard to do. You need thousands of patients. You need to follow them for years, and they all have to be placebo-controlled, because a lot of times, people in clinical trials do well. And when you have good follow-up and people pay attention and they treat every problem well, the placebo, the person who's getting the sugar pill, also does well. And so it's really important to have these placebo-controlled trials. And I know a lot of patients get upset saying, I want to make sure I'm on the drug. It's like, well, if we knew the drug worked, we would give it to you. But the problem is we don't know. And these drugs have toxic effects. So we can't just give it out and say, well, if it doesn't hurt you, it's not going to kill you, because unfortunately, they can kill you. And, they can make your disease get worse. So we have to be careful. And so we're obviously very happy when, the ongoing trials, after years of people being on it, continue to give some benefit. There are many different trials going on. Like I said, there was over 400 of them. They're all aimed at different aspects of the disease. Obviously, Alzheimer's disease, which is the most common, has received the greatest attention. But there's disease-modifying trials in progressive supranuclear palsy. The main problem we have is we need to be able to detect the underlying cause. If we can't do that, it's very tough for us to design trials. And that's been a rate-limiting step for us. So as we get better at figuring out who has what, we're going to have more and more trials. We have a lot of, ideas about future trials. There's some trials going on in insulin that has received a lot of attention, repurposing of some anti-cancer drugs, repurposing of all these drugs. So there's a lot of programs now to look at all these drugs that have reached the market, that have been shown to be safe, can some of them have an effect in Alzheimer's disease? So when you have a good model, you could put these drugs through these high throughput, I guess, machines and see, do any of them impact the disease? And so you could get through a lot more drugs faster, and they wouldn't need all that safety data. So, people are trying to be quite creative of, how to solve this. But until we have the drugs, what can we do? Okay, so our first step is really to try to figure out, well, what the cause is. So get an accurate diagnosis, and then really education. Education on the illness for the person, for the family members, for any care partner, the safety, risk to caregivers, removing dangerous items when we don't, when the person's insight is not as good. Driving, it's the bane of a lot of our existence, taking away people's driving privileges. Figuring out how to provide distractions, support groups, power of attorneys, advanced care planning. In terms of pharmacological, we don't currently have, outside of clinical trials, we don't have medications that cure or delay the disease for the ones that are caused by these underlying proteins. We do for vascular disease. Like I've mentioned, vascular disease dementia is really preventable. But we do have really good knowledge that treating medical conditions like infections, seizures, pain, improving nutritional status can have an impact on the progression of the disease. And we always review all the medications, because there's lots of medications that we take for one thing or another, and medications sometimes that we really need, but they can have an impact on cognition. A lot of routine medications that we take cross into the brain and will have an impact on the way you can remember and you can think. We think of people being in an optimal state, Think of yourselves now. If you're had a good night's sleep, if you're able to, really, you feel good, you've exercised, you're going to be able to think better. If your mood is good. So that's the same thing for anybody who's got any brain disease. And so we do try to get them into exercise programs, make sure they get good sleep, make sure that they're able to communicate with people and have ongoing communication. Physiotherapy, occupational therapy, socialization. There's a great, there's a lot of evidence that music can be really quite beneficial for people. And there's an iPod project in Toronto, which the Alzheimer's societies have, really, I think, moved forward with, and, really providing individualized music. In Alzheimer's disease, we do have some symptomatic treatments. So these are not clearly disease modifying. Okay? These are medications that we give for the most part because we think that they can help with some of the symptoms. In Alzheimer's disease, one of the problems is that people have a hard time registering information. So if you're going to remember only 50% of what you're going to see, and that 50% is only 2 items, that's not very good. So the acetylcholinesterase inhibitors, mostly known as donepezil, Aricept, or Exelon, galantamine, these medications can help people register a little bit more information. So if you can register 10 items and you remember 50%, well, you're doing much better than only 1. We treat mood. There's an NMDA receptor antagonist like memantine. Of course, if there are significant behavioral issues, we do have to treat those, even though, we try as much as possible to find other means like distractions, keeping people busy with exercise, things that allow you to sleep better at night. But if, let's say, you start wandering at night, or you're having a hard time getting the care that you need, then we do use low dose of antipsychotics. In frontotemporal dementia, again, we don't have any treatments available. We treat mood as much as possible, just because there can be some agitation, aggression. We're hopeful that in this field there was going to be some protein-specific treatments available, but we're actually not there yet. In people who have Parkinson's disease, dementia, and Lewy body disease, well, we try to treat the Parkinsonism with C.E.T. So carbidopa, levodopa is the medication that's classically used in anybody who has this Parkinson's disease to try to make sure they're less rigid and make sure that they can move a little bit better. We know that these acetylcholinesterase inhibitors that we used to use in Alzheimer's disease actually do work in Parkinson's disease, dementia, and Lewy body disease. And that's because we've actually figured out that there's a lot of people out there who have two illnesses in the brain. Unfortunately, one brain disease does not protect you against another brain disease. And so this is one of the reasons that it's been shown to have benefit. Antidepressants, like I've said, mood is really, really important. And there are some anti-alpha-synuclein treatments coming. Vascular disease, dementia, well, I think, like I've said, this is one of the diseases that I think we're going to make a huge impact in. I think as people become more and more aware that they actually have control over how this disease progresses or develops, we're going to hopefully see it on the decline. Exercise has been shown to have great benefit in vascular disease dementia. Some people do use these acetylcholinesterase inhibitors, and that's because, like I told you, you can have vascular disease dementia and also have Alzheimer's disease, unfortunately. So some people have shown some benefit. We like to show that there's Alzheimer's disease there before we give it to people, but it is a consideration. And of course, we think, really taking care of the care partners and the caregivers is really part of the treatment plan. We all know how much of a contribution they make to the well-being of the person. And so we do really consider that, these diseases are physically and emotionally exhausting. There's a lot of personality changes, behaviors that are distressing. That's on top of motor problems, the cognition. And so, depression is a real significant problem, as well as their own medical illness. And we actually have quite a bit of data that dementia, cognitive impairment has a significant toll on caregivers. 15.9 million family and friends provided 18.1 billion hours worth of dollars of unpaid care to those with Alzheimer's and other dementias. And this was in the US in 2015, and we actually know that that's risen. 2/3 of caregivers happen to be women, and 34% were over the age of 65. Unfortunately, you can see that their income has been hurt by having to, and I think lots of people know this, care contributors to over $15,000 loss of annual income. And 60% of the patients in this study said that emotional stress of caregiving was high or very high, and 40% suffered from depression. I mean, these are significant numbers. So, there's a lot of people not looking after their own health, and many of them really concerned about their own health. So we really do try to, give our care partners a prescription that they have to protect their own health, because without doing that, it really becomes, we know that the patients will end up in a worse situation. And to look out for signs of depression, a lot of times our care partners end up quite isolated. The patient maybe is not able to socially interact as much. And so we do often promote that, get them to a day program as much as possible, get them into their own activities so that a care partner can do things for themselves. We, ask them to acknowledge that they need help and to ask for help, and we try as much as possible. We have, fantastic social worker and nurse in our clinics to really find as much help as possible for them, and even financial help when we can. And utilize the community groups, advocate for more help as much as you can. We know that in dementia, the care partners are tired, and so it's a tough area to advocate. So we do try to let people know about that, but anytime you can, advocate for dementia care, I think you should do it. And, we do think it's important to educate yourselves on the diseases, how the disease progress, the different symptoms of the disease. A lot of times we know that memory is a problem, but I'll tell you that there's very few people who end up in a long-term care facility because of a memory problem. They end up there for other reasons. And so I think it's important to know what these diseases entail and comprise. And there's lots of, I think, these grassroots movements to really have, you know, support groups among peers, and I always hear that they're very beneficial. So to summarize, I think, you know, we really do believe that getting an accurate diagnosis is important, and it really is a first step to treatment. And I think as care partners, you guys are going to have to advocate as much as anybody else, because for the person who's coming, a lot of times, unfortunately, they're coming to us at stages where they're not able to really get an accurate diagnosis. There's lots of new discoveries, there's lots of new understanding, and there's lots of room for hope and optimism in our field, and that's why we're there. And I know sometimes it's hard to see that when people are progressing and we don't really have that much to offer. There's protein-specific treatments that are in the pipelines, and so this is kind of like a revolution in our field, because until not that long ago, people were just getting kind of, you know, symptomatic management. And we also really do promote that taking care of the caregivers is really going to be, you know, essential for keeping our patients better longer. So thank you all for coming and for listening, and I'm here if you have any questions. And you come to the microphone, because I think some of this is going to be broadcast. Yes?
Thank you for your presentation. It was amazing. It was nice and simple for people to understand, and it was great. And my name is Jane Teasdale. I'm actually from a home care organization, Mosaic Home Care. And I know you had mentioned in there about socialization, which is important. And as an organization, we actually have a resource center to help families in the community. We're the first in Canada and even the States to do that. And also we have social programs, knitting groups, hobby-based individuals coming in to talk about different things for the community. We also have joint partnership to run memory cafes with the Alzheimer's Society. So these are for people with early diagnosed of Alzheimer's and dementia. I also just actually came back from the UK, where I was asked to do a presentation on person-centered care. And we were also awarded a gold medal. Which is quite amazing, from getting recognized over in the UK for what we're doing here. And we've developed a model called the Meaning of Me. And this is for all our clients that we use to really understand the person, even though they have Alzheimer's, dementia, Parkinson's, cancer. We're taking it back to the person. Of course, the medical model is critical to understand that, but then we're doing another, not so much assessment, but finding out about the individual and the hobbies, and see what they still want to do. Yeah. Just because they have an illness, it doesn't mean that life is over, that they still want to have fun. So, so I just want to let people know about that, and that there are wonderful programs out there through many community organizations as well. You know, you were talking about support programs, day programs, for families to have a look at that. Also in the UK, they also have Carers UK. And they're trying, and actually here in Toronto, there is a caregiver coalition group. And again, we need to really recognize those family carers, is the term that they use in the UK, because they are stressed out. They don't know where to go. Where do they get the information? If they're not seeing a social worker or a doctor, where do they go to get the resources? And this is really important. So I just want to state those things.
Thank you.
Cheers. Thank you. Jane Teasdale. Yes.
Any other questions?
Yeah. It might not be specifically about dementia and all your medical knowledge, but thank you for your presentation. I was just wondering, you were talking about a caregiver, like low income, lower income, and spending lots of money. And is there anything in Ontario or in Canada where you know, they're thinking about maybe compensating us, like giving us money for caregiving? Because it's true, like this is becoming like very a big burden, right? Do you know of anything going on that I don't know that,
Yeah, no,
should we start a journey there?
Yeah, I don't know. And honestly, with, I was part of the Ministry of Health Long-Term Care in Ontario strategy for dementia, and now, there's going to be one for Canada. And there's so few funds going towards these initiatives that I can't even imagine that would be on the table. Because, even now, trying to get enough help for people is not, is really tough to envision. So I think that's really important. And I think that, this is a full-time job for many people. And, I think, parents have been at it for a long time, right? The parents of children with disabilities. And I don't know if in those areas people have managed to make any headway, because I would look there. They've been at it for a long time, yeah.
Sorry. As I mentioned before, the Caregiver Coalition group here in Toronto, and if you contact me, that is a group that is trying to make changes for families. Yeah. And, they're making the changes in the UK to try and make it easier for families, I don't know if it's, funding through the government or whatever, but they're doing that in the UK. We're much slower here to get things started, but if you call me, I can give you the contact of that group. Okay?
Yeah. Any other questions? Oh.
Is there one over there first? No.
I don't know.
Okay, I'll go first. I just have a question about, life expectancy with Alzheimer's disease, and also if you can explain exactly how Alzheimer's disease brings about end of life. That's a question my partner who has it often asks. He says, well, I don't know. He thinks, he likes to downplay it, of course, but it seems that this whole question of how exactly Alzheimer's disease kills you is one that we're a little unclear on, is partly because I think other things kind of kill you often before you get there.
Yeah.
But that's a question I would just like to ask.
Yeah, that's true. And, Alzheimer's disease, so in dementia, there's a spectrum. There's Alzheimer's, and the Parkinson's disease dementias are actually quite slow. So most patients have a slow progression of their illness. And obviously, you have to remember the disease happens on a backdrop of your own other diseases, right? So a person who gets Alzheimer's disease, I have people in their 50s and 60s who used to run marathons and they were super healthy, never took a medication in their lives. Those people, they'll have a fairly slow progression in the sense of, they were very healthy. But sometimes people will get Alzheimer's disease and they've had a few strokes, they have high blood pressure that's uncontrolled, they drank for many, many years. In that person, the disease will progress faster. What usually ends people's lives is, so like you said, in some people, this disease doesn't protect you against a heart attack or a stroke or, an pneumonia. But a lot of times, our patients die in a related disease, a related problem. So if our patients don't know how to swallow very well, they can get aspiration pneumonia. You end up, you end up almost bedbound in some cases where you have very limited mobility, you don't know how to walk very well anymore, you're not motivated to get up and around. And so those people end up with infections, they end up with clots. So the disease doesn't kill you in the sense of like your heart stops. But that's the same thing for cancer. How does cancer kill you? Right? A lot of times you get an infection, that kills you. So in a way, it's the impact of that illness from the brain, from the change in the brain, the impact on some other organ. So a lot of our patients do, at the end of their lives, have respiratory arrest. But that's because, they couldn't swallow very much, or they stopped drinking and eating, and really there was no more quality of life that we would think of putting in a tube or, force feeding them through a tube, basically. So that's the way people die. And that's if they're not dying from something else. Yeah. And I think you had a question.
Yes, good morning. My name is Aubrey Chalmers. I have a comment and a question. First of all, the question is, I've been caring for my wife for the past 4 years. She has primary progressive aphasia. About 2 or 3 weeks ago, she was hospitalized and diagnosed with diabetes. Before then, she could have walked from here to where you are without any help. And now since she has been in the hospital and came out, she can hardly walk. Now, before then, she used to regularly go to like day programs, karaoke and all these things. But subsequently, she can't attend those sessions anymore. My question to you is, how do I get her back into these programs based on her inability to really walk? And I'm faced with the challenge as to how to get her back into these programs.
Yeah.
And the comment is, I was listening to the radio or the TV the other day, and I heard the federal government is making some provision for caregivers, and that's supposed to take effect sometime in December. I'm not quite sure on the details of it, but as the days go by, if you listen or look at the television, most likely you may get some information on that. Thank you.
Thank you. So, you know, in our illnesses, people don't usually change from one day to the next, okay? Even in the diseases like primary progressive aphasia that we think are usually faster than Alzheimer's or Parkinson's, people shouldn't change from one day to the next where they can't walk anymore, unless, you know, they have a stroke. So something has to happen, you know, whether they have, you know, an injury, a nerve injury, a spinal cord injury, a stroke, something. Now, with diabetes, the problem is some people can feel quite weak until it's quite regulated, right? Like you could imagine if your sugars go down, even if you're not a diabetic, you can feel really awful. So it might take a little bit of time to regulate the new level. But I would imagine that if she didn't have trouble walking before, she should be able to get back up to walking. Now, the day programs also should be able to take people with diabetes. So that shouldn't exclude her from the day program. So yeah, we should discuss it. Maria?
Sorry, just to add to your question, there are some day programs in the community that are enhanced, so they provide additional support within the day program. So if someone was diabetic but required insulin, there usually is no nurse in the day program who would be able to administer it. So that might be a challenge for the staff. The other piece is mobility. So when people have decreased mobility and they require more than one person to transfer or to be taken to the bathroom, they might not have the staffing in order to do that. So some day programs are better equipped than others. So it might be worth a conversation of looking at what is available in the community and seeing if there's a better fit in terms of another day program available.
Yeah. Any other questions? Yes?
Thank you. My question is regarding Alzheimer's and Parkinson. Does DBS, deep brain stimulation for Parkinson, does that have an effect on Alzheimer's?
So there are trials in Alzheimer's disease currently to see whether it would be beneficial. But it's a clinical trial, experimental. We don't actually know whether it will have an effect. In Parkinson's disease, if you have cognitive impairment, you are excluded from getting DBS. So if you have a cognitive problem, if you have memory or executive or language, and you have Parkinson's disease, you can't get DBS unless it's very mild, you know, because there's a concern that it could make it worse. In Alzheimer's, it's at an experimental, because we know that DBS works quite well in Parkinson's disease. In Alzheimer's disease, it's at an experimental stage. Yes?
Question on Parkinson. Is DBS being used a lot for Parkinson?
Well, at this hospital, it's routinely used. There's lots of people who are, you know, it's not the first line of treatment for Parkinson's. There's lots of medications that can be tried before, because you could imagine putting something in your brain is not, you know, first line. You know, no matter what, you have to damage some part of the brain to get those electrodes in. But the benefit is so great for some people that it's worthwhile to do that. But it usually isn't the first line of treatment for people. Yeah. Any other questions? No? All right. Well, I'm going to thank you all for coming, and there's some refreshments and food outside, so please help yourselves. And you know, you're free to, we have this room till noon, so feel free. And there are questionnaires that Brenda will be passing out, so please answer them. You're going to help us design. This is an education series that this is the first session of the 4 that have already been designed. They were developed based on the feedback that we received from patients, and their care partners. But we're looking to create a year-long education series, so you'll help us develop the next 4 sessions. Thank you.
And I just want to thank Dr. Tartaglia for taking the time to speak today. It was very informative and educational. Thank you very much.